That's bad, Eugene. I cannot share my screen.
Why not?
I don't know. It's because of this new Linux thing. I should have.
I can do it.
Okay.
So,
Thank
yeah.
you.
Would you like me to do that?
Yeah.
Okay. Hi, everyone. Welcome back to week 7, the second last week of McMed Hacks. Today we have 2 wonderful speakers. I will go ahead and start get going, and I would just give a brief overview, like usual, on where we are in the program. Today is July 22nd. We have Dr. Udunna Anazodo and Dr. Samira Kahou to speak to us today. We are well in the 3rd week of phase 2, and I think most of you have been very much in touch with the filling the quizzes and accessing the Gumroad platform. If you have more questions, feel free to let us know. In terms of the attendance, we are going to issue the certificates in August. And as I mentioned, the arrow should be over here in week 7. And today we have 2 wonderful speakers, and tomorrow we'll have Dr. Parsa Bagarzadeh again to give us an introduction on transformers for our hands-on coding workshop. Today we have 2 wonderful mentors. We have Nicole Zhang and Charmi Chokshi. So if you are in the audience, feel free to turn on your camera and introduce yourself and say hi to everyone. They are going to give us a tutorial this coming week. If you have attended in the past, this is our mentors are going to go through an assignment relating to the topic of this week, which is transformers, and it's also a Google Colab notebook that it'll go through. For any questions that you have, you can reach out to them as well. Nicole, I saw you turn on your camera. Do you want to introduce yourself a little bit?
Yeah, sure. Hi, I'm Nicole. So I am a MD PhD student. Currently just finished my MD year 1, and I'm doing research on generative flow networks. And yeah, so feel free to hit me if there's any questions. Nice to meet you.
Thank you so much, Nicole. And Charmi, would you like to go next?
Yeah. Hello, everyone. Glad to meet you all and excited to learn along with you. I recently finished my master's in machine learning from Mila and University of Montreal. I'm an international speaker and a multiple award winner in the field of AI, women in AI, and women in tech. So feel free to reach out to me anytime if you have any doubts related to the topic. Thank you.
Okay, thank you both very much, Nicole and Charmi. Great. Now it's my pleasure to introduce our second-time speaker, Dr. Udunna Anazodo. And if you're a Spark participant, you should be very familiar with Dr. Udunna. She will talk to us today about an approach for, hold on. She would, wait, am I still sharing my screen? Oh, Udunna has shared his screen. Oh, okay, that's awesome. So I'll just 1 second.
Do you want me to introduce the speaker?
Yeah,
Okay.
Go ahead.
Okay, so it's my pleasure to introduce Udunna today. So Dr. Anazodo completed her doctoral training in medical physics at Western University and was a MITOX Accelerate Fellow at the Lawson Health Research Institute. She's a William Dawson Scholar and Assistant Professor of Neurology and Neurosurgery at the Montreal Neurological Institute at McGill University. She's the Director of the Multimodal Imaging of Neurodegenerative Disease Mind Lab at the MNI, where her group develops PET and MRI techniques for quantitative neuroimaging. She's the current chair of the ISMRM PET MRI study group She's very passionate about improving access to diagnostic imaging with a focus on population and global health. She's the founder and chair of the Consortium for Advancement of MRI Education and Research in Africa, also known as CAMRA. This is a global network of MRI experts working to establish sustainable access to high-value MRI in Africa through local capacity building. She also established the Medical Artificial Intelligence Lab at Crestview Radiology in Lagos, Nigeria, Africa's first AI lab dedicated to training, development, and implementation of AI applications in medical imaging. So thank you very much, Dr. Anazodo, for being here today and for presenting us a part of your work.
Thank you very much.
And take it over. Yeah.
Thank you, Sebastian. I guess you guys can hear me and see my slides, right?
Yeah.
Yeah, very well.
Yeah.
Thank you so much.
Thank you. And then, sorry, Eugene, I didn't mean to cut into your slide presentation.
No, it's okay.
I'm on my little Mac laptop, so I don't have the pleasure of seeing two screens.
Oh, that's totally fine. Please go ahead.
Fantastic. So thank you for welcoming me back. I guess some of you that were at the MICMET hack last year may have seen a little bit of what I'm going to present, but not so much because last year we talked a little bit about the challenges. This year we're going to start to show some of the work we're doing in Africa to sort of try to address some of the challenges that we talked about last year, but move towards being able to sort of establish a sustainable AI ecosystem for medical imaging. And I'm going to use Africa as an example, but what I'm going to discuss can be implemented in any resource constrained or resource limited setting. And what I tend to say is if it works in Africa, it will actually work anywhere. So let's just jump right into it. So I'm not going to belabor you with this, but we all know that when it comes to at least medical imaging or radiology, that AI has a huge potential. And that potential is actually way more, or would I say the value of AI it's way more meaningful in low resource settings, especially in places like Africa, where we can do things like using AI to improve the image contrast, image quality, and some of the suboptimal imaging devices that we have in the continent and still using the continent. AI has the potential for rapid diagnosis because we don't have a lot of subspecialized radiologists in the region, and AI has a lot of impact in terms of being able to take some of the complex. We still have issues with infectious disease. We're now moving into non-communicable diseases like cancer. So we have a lot more complex cases where big data can actually help to start to not just understand mechanisms, but even start to do prediction and prognostics. Obviously, the issue here is that with all of that being said, there is some challenges that we have to be able to resolve in order to now draw into and leverage that AI potential. So what I'm going to do is I'm going to use brain tumor imaging to sort of reacquaint everybody into how AI plays a role in medical imaging, and also use brain tumor imaging to conceptualize some of the challenges that comes with doing using AI in brain imaging to solve brain tumor challenges and to solve those challenges in resource limited settings like African clinics. So brain tumor, in terms of looking through from the let's say diagnostics. I don't know if you guys can see my arrow. Let me just make it red. So no.
We can see it.
You can see it?
Yeah.
Let me just make it a laser pointer. There we go. So from the, let's say, preoperative diagnostic stage to the treatment planning, to the actual delivering the treatment, and then to the post-op care. Throughout this entire pipeline, AI plays a role in terms of, we can start from just blood screening and diagnostics, focusing more on imaging. And what we do, we have a lot of things that AI can do, both from being able to segment, classify tumors, into getting into prediction, and even mixing imaging with genomics and stuff like that to be able to grade and understand the tumor very well, getting into surgical interventions that we can do AI robotics with, and post-operatively being able to predict recurrence and even try to do personalized, when we talk about personalized medicine, so developing drugs and therapy interventions that are really focused on the individual and the individual's biology. Throughout all of this pipeline, AI plays a role. And we talk about artificial intelligence, we're talking about everything from machine learning. So what most of you guys are doing at MICMET hack, which is supervised and unsupervised down to deep learning. It's also natural language processing, that plays a role when it comes to brain tumor imaging. We're talking about being able to, if you're talking about imaging, for example, being able to do speech to text reporting. That could be one way of looking at it. Medical reports tying in clinical reports from the lab to the imaging. So there's a role that natural language processing plays, down to computer vision for robotics and all the rest. What I'm going to focus on a lot is this section of it, which is where imaging, medical imaging plays a role, which is in the machine learning aspect of things. Now, again, just using brain tumor imaging as a template to conceptualize what we're talking about. For the past, well, I say 10 years or so, we've been able to sort of collect a lot of brain imaging data sets. And in this case, we're talking about brain MRI, because brain MRI is the modality that provides the most useful information in being able to see and understand brain tumors, classify, predict, and be able to do treatment planning. So when I talk about brain imaging for brain tumor, I'm talking about brain MRIs, and I'll show you some examples in a second. So over the past 10 years, we've been able to sort of use artificial intelligence, machine learning to be very specific, and deep learning to do two things. One is to segment and classify brain tumors. Segmentation allows us to do a little bit of detection of brain tumors, and classification allows us to do a bit of grading. So this meta-analysis that was done last year was able to collect information on the usefulness of the application of of machine learning techniques in detection and classification of brain tumors. They looked at 224 studies that did deep learning and the traditional what we call machine learning, again, for segmentation and detection tasks. And what we're able to conclude is that we've come a bit far, or what I say, we've come a bit fast in being able to adopt some of these novel deep learning techniques to segment brain tumors just as good as radiologists, who are the experts, can. When it comes to detection and being able to classify, being able to sort of characterize the tumor, it becomes a little bit of a challenge, and there's still work to do, but we're getting there. So well, I say long short of this is that AI is becoming very useful when it comes to brain tumor segmentation and classification. But then when we come down to resource limited settings like places in Africa, where we still use lower field MRI devices, because again, like I mentioned, when it comes to brain tumor imaging, MRI is the modality of choice, and that's a modality that's actually standard of care. So in places like Canada, in places like the US or in Europe, well-researched settings, we do have high quality, high resolution brain MRIs that really allow us to segment and classify and detect these brain tumors. But in Africa, low field MRI is still widely used. So we have 40% of MRI clinics or imaging clinics in Africa still use low field MRI and have very low resolution, poor quality images. The scanners oftentimes are not well maintained, so they're not quality controlled. So you do have a lot of noise within the images. You also have some optimal protocols that are suboptimal for imaging in low field, and even suboptimal for imaging brain tumors. So this becomes a huge challenge. And I'm just going to work you through why we need to start thinking about how to still use AI, which does play a big role in being able to provide tumor detection and diagnostics in low resource settings. So again, if I were to compare the data sets that we have from, well, I say high income countries or countries where we have a good resource in being able to provide high quality or high resolution brain MRIs, we find that the images we tend to get, and these are brain MRIs, are typically high contrast. We have very good contrast between gray white matter. You can be able to see the tumors a little bit better. You have at least a 1:1 isotropic resolution. You have multi-parametric information because you need that to classify and characterize the tumors very well. So you have the typical anatomical T1 weighted and T2 weighted MRI sequences. You have your flow that allows you to see a little bit of fluids. And then you have your post-contrast when you give a contrast injection that allows you to actually be able to see that tumor very well. For example, if you look at the T1 post, before you injected the contrast, and the T1 post-contrast, you see that the tumor is well enhanced here. And then you have diffusion weighted imaging. The thing is that these are multiple parameters that we can combine with AI, giving us a lot of data sets to be able to characterize the tumor very well. In high resource settings, we have hundreds and hundreds of cases. For example, the brain tumor segmentation challenge run by the Medical Image Computer and Computer Assisted Intervention, so the MICI Society, for almost 10 years now, and provides a lot of open source, so anybody can access these data sets, lots of training cases They started with 369 cases. It's actually gone to over 600 or 700. So the cases have doubled. So you have hundreds and hundreds of cases to use to train and develop the AI models. And the same thing goes for, this is a stroke example, just to tell you that this is not just for brain tumor imaging, but if you look at any medical, medical application where AI plays a role, there's hundreds and hundreds of images that are actually open source right now. And if we were to flip and look at low resource settings, so this is an example from Africa, we find that again, the images tend to be low contrast resolution, they are lower quality, you don't have the ability to collect multiple informations. Contrast is very expensive. Some centers don't actually give contrast, and when they do, they give half a dose of contrast. So the resolution and enhancement is quite poor compared to the West. And in some cases, they don't have the ability to do diffusion weighted imaging. So you have fewer information to now be able to develop a richer and robust AI tool. And in the case of Africa, there's actually no public data set, and I'll tell you what we did to solve that problem. And when you do have, or when you try to curate data sets for trading, you find very few cases. And that's because in places like Africa, where people pay out of pocket to seek care, they oftentimes tend to not be able to afford medical imaging. And when they do come, they come much more delayed when the cases are more complex. So you don't have access to a lot of cases to start to build your models. So when we combine all of this in all of these challenges, the challenges of having low resolution data, poor data quality, not so much information, and very few cases, we see that, if we were to take all of these applications that I talked about here, where we have all of these methods that are now showing, performance that are just as good as a radiologist can, the question is, can we take some of these methods and apply it to the data sets and the data challenges that we have from Africa? And the answer is no, we can't. So Dong Zhang, who is a master's student, a PhD student at UBC, while he was at my lab, we've looked at, some of these top performing models that have been sort of validated on brain tumor images and stroke images in the West, mostly from the US. And what we did is we tried to take that same data set and now downsample it. So essentially simulate data that is equivalent to the type of data quality, contrast challenges, and few cases that we have in Africa. And we actually had a few African cases that allowed us to do that. And I wanted to know how well those methods perform. The long story short is that they obviously don't perform very well. This is 3 cases where we see that oftentimes they missegment the tumor, they misclassify the tumor, or they essentially not even able to segment it at all. What Dong did was Dong, in his model, have obviously paid attention to some of these challenges, the few cases, the low resolution, as well as the noisy imaging challenges, and was able to develop a method that can segment brain tumors and lesions, because this is actually some of the cases are stroke cases, when we actually start to pay attention to some of these challenges. And you can read more of his method in the Mikai paper that was published in LNCS, so in Lectures in Computer and Lecture Notes in Computer Science. But what I want to talk about today is how we can start to address the challenges that we have in being able to provide that ecosystem for medical imaging in low resource settings like Africa. And what we've done is we've been able to sit down and actually try to understand what these challenges are, because if we can't understand your problem, you can't actually solve it. If you try to solve problems without understanding, then you create trade-offs, you don't create solutions. So we want to be able to really understand the barriers that we have to then create sustainable solutions that can actually sort of unlock the potential of AI in places like Africa. So there's infrastructure challenges. For example, we talked about the data quality, which comes from the fact that the scanners are what they are. There's obviously network connectivity, there's archiving and access to images, to computer facilities, that being able to even have computational infrastructure is obviously a big problem. There's problem with personnel, they're sub-trained. So people have to obviously create the ground truth. Informatics skills and computation skills are quite lacking when it comes to computation skills in medical imaging. And obviously there's data governance and privacy concerns, because these are medical imaging data sets, and we have to have the ability to be able to have the right policies in place that allows AI applications to be applied in medical imaging. In terms of infrastructure, like I said, there's the predominance of really lower quality devices. Yes, lack of storage and ability to sort of archive these images so that we can use them in AI applications. The computation hardware is very expensive, much more expensive than in the West, and obviously lack of stable network connectivity. You know, the clinicians, now I will illustrate this in a second. The clinicians are really subspecialized in novel trained, same as the medical physicists, the people that provide us with the images. There's obviously lack of imaging informatics, and biomedical research expertise is also lacking. When it comes to policy, funding is a big problem because without funding, you're not able to fund the infrastructure or train the personnel. And in Africa, funding comes in from outside, meaning that the local or the regional governments or national governments don't actually fund research, let alone fund very expensive imaging research, like MRI. The scanners are expensive, and so are the ability to actually generate the data sets. So we have to figure out a way to have stable funding where we have donors, because most of the funding research in healthcare comes from Wellcome Trust or the Gates or the Chan Zuckerbergs, so Facebook foundations or stuff like that. These foundations are very focused on infectious disease and maternal health, places where medical imaging typically is not the standard of care. When it comes to cancer or dementia or heart disease, where imaging is standard of care, they don't really see the need to start to fund that because they don't see this as a problem for low resource setting. So there is work to do in terms of policy to start to be able to plug in the gaps. I'm going to use this to illustrate what I mean by the challenges when it comes to data acquisition and when it comes to personnel. This is a workflow for brain tumor segmentation or for classification, so segmentation and for classification. So for you to be able to actually apply AI, you have to be able to have the data set. So you have to have somebody provide that interoperable data collection, which means that you do have to have the right personnel and the infrastructure to do that. When it comes to being able to create the ground truth you need for segmentation, you obviously have to have the right expertise as well as the infrastructure. So the software that allows you to actually do that segmentation. And obviously you do require the computational skills, and these computational skills have to be multidisciplinary because you have to be able to understand the imaging, the oncologist, the neurosurgeon, they all have to provide input in being able to actually create a model that can segment tumors very well, just as good as the expert does, and can actually provide some gradient. So when it comes to Africa, there is a challenge with having trained neuroradiologists, subspecialized, trained neuro-oncologists, trained neurosurgeons. Some of these trainings don't actually exist in most countries. And the computer scientists are not very well versed when it comes to medical imaging. So what are we doing to solve that problem? You know, for you to be able to create a sustainable AI ecosystem that can start to provide local solutions for medical imaging, you have to take those experts and train them very well. So we have to have a lot of trained experts in place. We have to figure out how to optimize the infrastructure that we have, and we have to figure out how to find stable funding. So at Camera, what we do is we're trying to, our main goal is to create an unbroken chain of resources. That resources includes expertise that can enable Africa to use the MR infrastructure they have to solve their local healthcare needs. And we do this by putting together programs that train experts in place where they are, put them within a collaborative network. So even if they're isolated, they're still able to work together and optimize the infrastructure we have. This is a picture of Dr. Jones Obongalosh from university in Uganda that builds open source brain MRI scanner. This is a scanner that he built for brain imaging in Uganda. I'm not going to spend so much on this. So we do have a framework that we've worked out. We talked about advocacy, being able to get a local and regional government partners to start to fund medical imaging, especially when funding comes from outside. We want to have a lot of that funding directed also to medical imaging. I'll talk a little bit about the training and networking model that we have, because when you have advocacy, training, and networking, now you can actually start to provide access for any healthcare, including being able to have access to do AI for medical imaging. A lot of these are summarized here, so I'll just have you guys go and read that. But the entire framework is a way to actually train experts in place, optimize infrastructure, and create collaborative networks. Now, using a project that we've done here in Camera to sort of start to demonstrate the solutions we have in place, we've taken those challenges of infrastructure, personnel, and policy and sort of mapped it around this African Neuroimaging Archive. The idea is to create an ecosystem that will provide not just high value open data sets, but be able to apply them and also create the policy framework for that. In terms of infrastructure, we've built this medical artificial intelligence lab in a private practice in Nigeria because medical imaging or radiology in Africa is dominant in private practice. 60% of the services are provided by private practices, and most private practices have those, well, I say, more advanced medical infrastructure. So within this private practice, we've put in a computational lab, put in data archive, have stable networking thanks to the Starlink. So we have a Starlink in the lab right now and access to data. What we're trying to do is, in terms of infrastructure, is to create an open PACS or free data archiving system. So when it comes to medical imaging, pictures or images are archived in this picture archiving system at local hospitals. And most hospitals in Africa don't have this because of the challenges with being able to run a PACS system, and we're trying to solve that by creating this open source PACS. In terms of infrastructure personnel, we have a trained medical physicist now, we have an IT scientist, and we've run a program which McMed Hacks was very good to help us with, and I'll talk about this in a second. That allows us to train scientists, and I'll give you an example of what we did in terms of brain tumor segmentation. In terms of policy, we have set up an ethics framework because, again, if we're trying to make sure we create an AI ecosystem for medical imaging, we have to bring in the private sector. So we have to bring in those private clinics that have a lot of imaging data sets and the private clinics where patients actually go and seek care. We have to help them understand how research is done. So we're creating the ethics framework with data governance recommendations that will allow us to be able to do AI within the type of imaging systems and settings we have in Africa. And in terms of policy, people tend to forget the importance of networking and what network can do to actually allow us to create a policy that can flow across multiple regions or countries. So I'm going to tell what we did in Spark, trying to use a collaborative network to create imaging guideline protocols for brain tumor segmentation. Networking and collaborative network is very, very important for healthcare because when it comes to most healthcare conditions, they're very complex. Again, using brain tumors as an example, we know that the patient itself, when they come in to get care, even if we're talking about now moving to precision medicine, we need to have the neurosurgeon, the radiologist, the pathologist, the biomedical scientist, the bioimaging scientists, and the computer scientists all working together to be able to provide and use data to provide treatment and decision-making for the neurosurgeon who is going to plan the surgery, diagnostics for the radiologist, and obviously pathology, and the pathologists that provide diagnostic information. So how do we bring all of these people together in a place like Africa where most of them are isolated? So the pathology clinic is in a different place, the radiologist is a different place, and so is the neurosurgeon. How do we get to do this? And this is something that we've done in Africa, and I'm going to demonstrate and show what we did using Spark. So one of the first projects that we did under this African Neuroimaging Archive is the Brain Tumor Segmentation Africa Challenge. Now, this is a challenge that we've done with the MICAI Association and led by Spyros Bacchus, who's been running this Brain Tumor Segmentation Challenge at MICAI for over 10 years. Now, this year is the first year we're going to provide data sets that are outside of the US or Europe or Canada. So we're going to provide African data sets for the reasons I demonstrated to you before. So this time we're going to try to encourage our global community that participate in these challenges and create models that will also be useful and applicable to African settings. So we actually provided data sets for the Brain Tumor Segmentation Challenge. What we did, we also wanted to make sure that we're creating the capacity. So we trained radiology residents to annotate those data sets. So that way those radiology residents can then retain the knowledge and continue to annotate data sets for other types of brain imaging challenges. We created this Spark, the Sprint AI training for African Medical Imaging Knowledge Translation Academy, and Academy is still going, as you can see. We started in April, and we were very fortunate to have McMed Hacks, and I'll tell you a little bit more about this. The goal of this is to not only train, but provide a network that will sustain the innovation. So we're training trainers that would train other people. We're using collective intelligence because, like I said, we need to have this network of neurosurgeons, radiologists, working with physicists, computational scientists, as well as with radiologists to be able to create an AI application that will actually be robust to solve the problems that we need. So we have to figure out how to use this collective intelligence to train an interdisciplinary network of of, let's say, researchers and scientists. We use a case-based method. So with the case-based here is the brain tumor segmentation challenge. And the idea is to get this students trained in a way where when they leave the program, we're actually able to provide deployable imaging solutions and also incorporate research skills, because like I said, biomedical research skills is very lacking. So we actually developed the program in a way that we can incorporate conference paper writing, journal paper writing, presentations, and grant writing. And then we use this teach, try, use approach. So this is the approach where we can take a novice in the sense they could have some radiology knowledge, but not medical, but not computational. They could have computational skills, but not medical imaging. The idea is to train them in a way where they have skills for computational imaging applied to medical. So for computational science applied to medical imaging, and take them from a trainee to a trainer. And do this in a progressive way where we're incorporating networking and incorporating those research skills. So we did this teach, try, use. We had MIGMET Hack come in and provide us with the foundational knowledge that brought everybody up to speed. So we had computational skills as well as medical imaging within this workshop phase. And then we had a 1-week hackathon where we provided them with past brain imaging data sets. Like I said, BRATS have been running this challenge for a while. So we took the past BRATS data sets, took those top performing models, gave them the code, provided them with the computational infrastructure, and actually had them try out all that they've learned during the workshop. We're now in a use phase where they've taken all of that knowledge that they've tried out, and they're now creating their own methods for this year's brain tumor segmentation challenge, which included images from Africa. And so we have about 10 teams, 70 scientists from 15 countries in Africa. We've put them together in a network, and we have 10 of them going through to provide us with 10 methods, which they're going to publish at conference papers, which will eventually turn into full journal presentations. And we're hoping to take one of those AI methods, optimize it, and then essentially put it into something like Slicer 3D, which is an open source viewer tools that radiologists can actually use. So we've gone from, essentially trying to, just train people for the sake of training, but want to be able to sustain this. So we're designing the program in a way where we can actually have teams, like mini labs, if you want to call it that way, mini labs that could continue to work together. And I'm not going to spend too much time here, but we want to be a bit mindful of a lot of the work that some of the MIGMET Hack team did, like Sebastian, Eugene, Leah, Pasa, Hussein. They were very helpful in being able to sort of supervise and provide a bit of mentorship to the African scientists that are working together. And I was just going to give you a quick, report of some of the impact of this training. This is the team from Ghana. This team is mostly radiographers. The teams from Nigeria, who are mostly medical physicists. This is the team from Lagos, Nigeria. The team is all this is essentially all radiologists except for the medical physicists. We have the team from Cameroon, from Ethiopia, from South Africa, from Kenya, and from all over Africa. And the idea is to bring that collective intelligence together to actually help them create informed biological and physical informed models. Our challenge is listed on here at the MICAI Brain Tumor Cluster of Challenges. The challenge is almost done, so it will be a bit late for you guys to participate because we're now moving into the validation phase. But next year, we're going to run this challenge again. And we're hoping that we could again provide the data sets and actually have the global community help us in being able to create this informed models. If you want to know more about the challenge, the archive paper is here. We will obviously publish the full paper later on. For the sake of time, I'm going to again just touch on what we're trying to do within camera to again plug in all the gaps we talked about. So the Spark training that I mentioned before was to train experts with the data sets that they have to be able to provide, at least using brain tumor as a model, to be able to provide AI methods for brain tumor segmentation. Now, the issue I talked about before is the quality of the data. And we're trying to sort of figure out how to solve that quality of the data issue. So we created this Scan With Me program, which you can use this teach, try, use approach to train radiographers or techs that acquire the medical imaging in clinics in Africa to be able to provide us good quality data. One thing we have to note is that in Africa, there is really no there is a lack of dedicated biomedical research. So in medical imaging, there's only one dedicated scanner for research in the entire continent. That's going to happen to be in South Africa. So the rest of the imaging devices that we have for brain tumor imaging or for MRI is in clinics, it's in the hospitals. So we have to figure out a way to train hospital radiographers to create good quality data sets that we tend to create here in the West within the research sphere. So this is what we're trying to do here with the SWIM program. The first program is going to start in September. I'm going to use a case-based approach, and the idea is to train techs that will actually provide us good quality data, not just for AI, but for clinical use. Now, for the sake of time, I'm not going to go through every single program we have at Camera, but the gist of the programs that we have is the programs that are built to provide sustainable imaging capacity in Africa by training experts in place. I've talked about Spark and SWIM, by optimizing infrastructure, and by creating collaborative networks. And we believe that when we are able to sort of try to use this ecosystem of plug-in infrastructure gaps, personnel and policy by training experts, by using creative networks and optimizing infrastructure we have, and making sure that we have a collaborative network that will actually start to provide a sustainable ecosystem that will now provide people in low resource settings the, let's say, power of experience to not just be people that tend to provide data sets or people that tend to use methods from outside. They will actually start to become experts that will now provide information that the West can actually benefit from. I'm going to stop here for now, just for the sake of time, but I do want to thank McMed Hacks for the invitation. This is the AI lab in Lagos. This is the Mind Lab in Lagos with Maruf. Dr. Fatade is the radiologist and the medical director of the lab. This is actually his clinic. And Dr. Toyabo is a radiologist there. Anu and John, God, I keep forgetting his name, are the IT techs, and these are the computation infrastructure that we have. The lab have a space to train 10 people, and it's a climate-controlled space. And I also want to thank my students who have been very patient with me while I do some of this traveling and AI work, and they all sit down and do fantastic PhD work. So I'm going to stop here and I would do thank you, and I'm happy to take questions.
Thank you so much, Udunna, for this very, very inspiring talk. It's very, very nice to see all of these efforts coming to like real results and something like really nice being built in a resource-limited countries. So thank you very much for your presentation. So now we're going to move on to the question period. So feel free to put your questions on the chat and I'm going to ask them, or if you prefer, you can also unmute to ask your questions. So I'm going to start with a question from Sami Bahi. Hello, you said you need local experts. What is specific to Africa in medical imaging that is different to Canada and that should be taken into account when training or deploying models? Thanks.
Oh, there's a lot. So let's just cycle back here to, I'm just going to go back here. Sorry, just give me 1 second because I'll use that to illustrate. Okay, so what's different? Let's talk about infrastructure being different. In Canada, first of all has universal healthcare, meaning that if I were to, if somebody has brain tumor and need to have a medical imaging, they could book an appointment, come into the clinic, sit down in a 1.5T well-developed MRI setting where the physicists have optimized the sequence. There's a clinical workflow. The neuro-oncologist and the neurosurgeon have already thought about how to plan for this patient's treatment, which is why they send them there. And the patient is getting good access to care, which means that the images are optimized for the therapy that the patient needs. And the patient pays $0 for it and walks away. Now, if we have 1,000 patients or 1,500 patients across the country that have this type of disease and know that they can pay for it, they will go and seek care, and they go and seek care much earlier, meaning that the type of images that we get from Canada in the pre-op, the diagnostic phase are patients that are less complex cases. Flip to Nigeria, Africa, for example, patients pay out of pocket. They don't have a lot of neuro-oncologists or neurosurgeons. They start with the symptoms. The symptoms often gets misdiagnosed. So by the time the patient actually gets to have an image in the case and affords to have an imaging, they are now in delayed and complex cases. So we actually try to pull together these images. We have patients that are now in complex cases where they've oftentimes misdiagnosed. I'll give an example. TB is very common in Nigeria and Africa. TB also has neurological outcomes. There are TB patients that have images that look like glioma, like they have images that look like brain tumor. And if you were to do radiation oncology on those cases, it will fail because the origin of that case is not from a pathological or, a tumor origin. It's an infectious disease that you can treat with viral infections and the tumor actually shrink. The same goes for other types of infectious disease that do have lesions that appear as brain tumor. So that's one. The second thing is that when it comes to personnel, where we are in McGill, I am a physicist, and so is Shirin. And we have a whole group of physicists around us. We have a whole lab of clinicians that are multi-specialized around us. So if we wanted to do this type of research in McGill, it will require us to write a grant to a federal or provincial body and get funding. If I were to do this project in Africa, there's zero grant for us to do this type of work anywhere within national organizations except in South Africa. So we have to go outside to find funding to be able to do this. And funding for global health, which is where Africa tends to fall when you go outside of Africa. So in Canada, for example, if I were to look for grants to do this work in Africa, I'll go under global or public health. When you go under global or public health, you're left with maternal health or infectious disease. When you write a grant for global health, you're given, like, let's just say $500,000 in the max. $500,000 will not even be enough for you to pay for people to get scanned in Africa. But that 500,000 will go a long way in being able to provide malaria care or antiviral care. And so when you have grants submitted, they would downrank your grant because to them, the impact is very small. And I could go on and on. But the biggest challenge between the two places is the, will I say, political will of both scientists, both funding agencies, and both clinicians to be able to actually invest in AI. Most clinicians in Africa see research as luxury because they work a lot of hours, more hours than their clinical counterparts. In imaging, for example, a radiologist reads everything from ultrasound, X-ray, CT, MRI, from head to toe. No radiologist anywhere in Canada does that, none. And so when you have this radiologist now that's doing brain imaging, MRI, and will I say MSK and X-ray for COVID or for lung, and you tell him to now use the little time he has to provide AI solutions or work on AI solutions, he doesn't have the time for that. And a lot of them don't even understand the research infrastructure. So the long story short is that how will I say medicine or imaging is practiced in Canada is night and day to how it's practiced in most places in Africa. And I hope that sort of answers your question.
Thank you so much. We have a raised hand by Dr. Anger. So if you want to ask a question.
Yes, so I'm sorry, I'm taking space from the participants, but Udunna, I listened to a very interesting presentation by radiotherapy treatments in Ghana when I was at American Brachytherapy Society. It was a radiation oncologist from Ghana who presented. And just to tell the participants the difference between Canada and Ghana when it comes have to use, for example, imaging also not just for AI, but for treatments. She had a very inspiring presentation telling us that, first of all, this treatment was only available in the capital of Ghana. So people all over Ghana should travel very long distances to come to this clinic to receive radiotherapy. And the oncologist, for example, can prescribe imaging, but many times the imaging is not even at the radiotherapy center. They have to go elsewhere to do their radiotherapy imaging for the planning, for example. And obviously, as some of you know, it is very important that the imaging is acquired in the same position as the patient will be treated. So obviously this is, we don't know how this happens when they do imaging at another center. And also, as Udunna says, the patients pay out of pocket. So this radiation oncology told us that many of the patients never come back because they don't afford to pay out of pocket for this very important imaging. So many of her patients just disappeared. She didn't know where. So the comparisons are, and when she told us this, this could be a woman with a very severe cervical cancer traveling from other side of Ghana to this clinic to receive treatment, and then she does not afford imaging to treat her lesion, so she has to go back. So the differences are not even comparable. So I think after hearing this, it is as it is, but lots of things to be done.
No, that's right. I mean, I'll give you one example. When I was in Nigeria in 2020, I went to a stroke clinic. The clinic just offers stroke care. So that's all they do is stroke. And the patients come from all over the country. Some have traveled 2 or 3 days to get there. These are stroke patients. I don't know if anybody knows what stroke is, but these are real stroke patients. And they come there with the CDs for their CT and MRI scan so that the stroke neurologist or interventional neurologist can actually start to figure out how to take care of their stroke. And some of the patients come with the wrong CD, like the wrong imaging file, because the clinic where they've gone to have the imaging done in a different state burned the CD. They're so busy they didn't even check and gave them the wrong CD. They have to get back on the bus, travel back 3 days, get the right CD, and come back for their care. Now, that never happens in Canada. If that happens, people will actually fire whoever that's running that place. So it doesn't happen. But I think the main important thing is how can we start to figure out how to solve some of these problems? And I see some questions here asking for, if I could go back up, says asking for collaboration. I think 2 people are asking for collaboration. One person was asking how they can participate. Well, I would say just not to take too much time is you can email me. I'll reach out to us. You can, I mean, if you contact anybody from McMed Hacks, they can connect you to me and to some of the programs we're doing. We're going to run Spark again. This is a website. And when we run Spark next year, we'll again try to do multiple use cases. You can collaborate by, either helping us train people. You can collaborate either by providing any open source tools that you have that we could test on a data set. You can collaborate by just kind of coming in and seeing if we have any cases that you can actually help us provide tools for. So there's so many avenues to collaborate, and we're happy to do that. So just reach out to me. And I think I'll take one more question, Sebastian, before the next speaker. And somebody asked, how can we bring research funds to Africa in the field? What about automatic radiology? I mean radiology without physicians. I think, okay, yeah. So I get this all the time. I get this question all the time. And this is one place where I think AI becomes something for us to consider how useful it will be. So first question about research funds. How can we bring research funds in Africa? I think one thing I'm trying to, for us Africans, and Sammy, I think for Minimi might be one, to avoid the ability of dependence. We're very codependent on the West. We're codependent on the West for research funds. I think we have to start to figure out how to turn what we've done in fintech. In financial tech with AI, there's a lot of startup companies that are popping up all over Africa for point of service machines or for banking and all this stuff. And we're doing a good job at that. I think we have to figure out how to start turning some of these medical innovations into something that we can capitalize to then fund back into being able to do research. So we have to generate our own wealth internally and not depend so much so on funding from outside. And so one thing we didn't do this year in Spark is entrepreneurship. So next time we run the program, we want to include entrepreneurship so that students can actually learn how they could start to take some of these solutions and market them, monetize them, and then put that money back into research. I think that's one thing I'm interested in. And so we're not so codependent on the West, because our governments will not put money into biomedical research, especially medical imaging, because it's very, very expensive. It's going to cost $5 million. $5 million is oftentimes the budget that a whole country has for healthcare. And when it comes to automatic radiology, or what I think you're talking about is being able to do remote scanning, or being able to do teleradiology, or being able to do something where the physician is not well needed, I think that's a bad idea. And what I will tell you why. Because we don't apply that same idea to the West. We don't say, okay, well, let's just do teleradiology where we don't need radiologists in Canada or radiologists in the US. We know that we have radiologists in the US, and we're thinking about how to augment their work with AI. I saw a picture or a meme where, and I don't watch this show, but Game of Thrones, where the dragon is AI and the writer is a radiologist. That's how radiologists view AI in the West. However, when you come to Africa, they essentially turn it into where, I don't even know what the analogy is, but where we don't need the writer anymore, and that the dragon is the one doing everything, because Africa doesn't have enough writers, for lack of a better word. What we need to do is we need to figure out how to apply AI where the radiologist is still the person using the service or using the tool to provide services. AI cannot read complex cases. We already know that from the brain tumor segmentation work that we've done for the past 10 years. AI cannot solve issues where you have a patient that comes to your clinic with, and just like what Shireen said, with what appears to be brain tumor that turns out to be TB. The patient goes to a radiation oncology clinic at a different place. That radiation oncologist is run by another AI machine. And like we can't do that. We have to start thinking about how we can use AI to augment and optimize the infrastructure we have, but not to replace physicians and not to replace how we acquire data, if that makes sense. Okay, so I'm going to end here. I'm going to turn it over to Sebastian. Thank you so much for your time. I will have to sign off because I have to jump off for another meeting, but this has been fantastic. Reach out to Shireen or Sebastian or Eugene, and they will figure out how to connect you to me. Thank you so much.
Well, thank you so much, Dr. Udunna and Anazodo, for your time. We know that both you and Dr. Samira Kahou are a professor. You have courses to give, you have supervision to be made, and you still take the time to come and present with us on a Saturday morning. So thank you very much for your time. This was a really interesting talk and it raised a lot of interest. So yeah, feel free to reach out to us if you want to connect with Dr. Anazodo. And now I think it's a perfect time to move on to our second talk of the day. So I'm going to introduce Dr. Kahou right now before she can share her screen and present. So Dr. Kahou is an associate professor at École de Technologie Supérieure in the Department of Software Engineering and Information Technology, and an adjunct professor at McGill University in the School of Computer Science. She's a member of the Quebec AI Institute, also known as the MILA, and of the research regroupment in artificial intelligence applied to critically ill children at CHU Saint-Justine. She's also a Canada CIFAR AI chair. Samira received her PhD in computer engineering from Polytechnique Montréal and the MILA. Before joining ETS, Samira worked as a postdoctoral fellow at the McGill School of Computer Science and as a researcher at Microsoft Research Montreal. Samira and her group focus on improving representation learning for sequential decision-making and applied machine learning. As a member of the regroupment, she works on applications of machine learning for patient monitoring and drug dosage adjustment to support clinical decision-making in ICUs. So feel free to take it over, Dr. Kahou, and share your screen.
Okay, I'm not sure if it's working. Can you see my screen?
Yeah, that's perfect. We can see your screen.
And is it full screen now?
Yeah, perfect.
Okay. Okay. So thank you so much for joining my talk on weekend. Today I talk about deep reinforcement learning for drug dosage recommendation. As Sebastian already introduced, I'm a professor at ETS and adjunct at McGill, and I'm a CIFAR AI chair. So the talk that I have today is a bit more about a bit more machine learning, and I present some technical stuff. So first of all, I want to talk about why AI is important in healthcare system. The first thing we know that we have a very strained healthcare system, and during COVID pandemic, we kind of all noticed that we need a very robust healthcare system. There's also a statistic Canada that says like by 2030, we will have 25% of Quebecers who would be at the retirement age. So that means that there is going to be increase in demand in healthcare. And then there are studies that shows that if you have overwork, burnout in healthcare system, that kind of reduces the quality of the care. So keeping this in mind, when it comes to intensive care, it's even when you need to make decisions pretty quick, that's even more has more strong effect. Now, what are the potential of AI for clinical decision support? So we all know that there are some limitations in existing treatment recommendation systems. For example, a lot of the things that's currently used in ICUs are kind of based on set of rules. We only take into account a subset of variables that we use, and some of the important factors are not considered. For example, if you have comorbid diseases. Now, the power of machine learning comes because we can benefit from a large volume of data for patients, and we can kind of present a personalized care. And there has been like an evidence that deviation from clinical protocols can improve treatment in intensive care. And last and not least, machine learning can also be used to identify patients at risk of complication and kind of enables earlier intervention. Now my expertise is on like deep learning and reinforcement learning. So that's why I talk about reinforcement learning today, and why RL is overall important for decision-making in ICUs. So we know that like the critical care is highly dynamic, and clinicians have to make many decisions and rapidly adapt to changes in the patient condition. And then the RL framework is a good fit when it comes to sequential decision-making tasks. RL methods also can learn policies for decision-making via trial error, and they aim to kind of maximize this cumulative reward, which when it comes to the healthcare, we can define those to be the patient's well-being. So here I want to give a very quick overview of what is the problem of sequential decision-making and what is reinforcement learning in general. Usually when we want to solve a sequential decision-making, we frame it as a Markov decision process. So in that case, we usually have an environment and have an agent. So the agent interacts with the environment and takes an action. And the environment in return gives you a reward and the next state. So the reinforcement learning methods usually learn this behavior, like a policy that tells the agent what is the optimal action in a way that can optimize like a cumulative reward over the time. Now to put it like in just like a mathematical form, we usually present the policy with pi, which is from a set of states and action to reward. Here we just define 0 and 1. And this is like would be a probability of like agent selecting action A when it comes to state S. And that defines the behavior of the learning agent. The objective here again is that we want the better return over time. So we want to, let's say in medical case, we want a better state of the patient. And then RL methods commonly involve estimation of value functions as well, which computes the expected return for following this policy, starting in a state S. So if you, for example, start in a state S, you can also compute a value function that tells you if you take this action, you can expect this much of reward in future. Now coming to the drug dosage recommendation for RL, in my group, we currently studying sepsis. And that's mainly because sepsis is the leading cause of death in ICUs and is pretty common. And it processes it very rapidly, so it's very challenging for clinicians to act. And so even though many medications are useful, but like the common ones that are IV fluids and vasopressors, that's something we can study for dosage recommendation. And also there are several initial studies that shows that this RL methods actually are promising when it comes to dosage recommendation. Now, how do we state this problem as an RL problem? So we define the task as that we want to adjust this dosage of IV fluids and vasopressors for sepsis treatment. Our states are the patient data, so their demographic, current vital signs, etc. The action here is discrete, and there are 5 dosage options, each from IV fluid or vasopressor. So that results in 1 to 25 action space. And the reward is, and the reward we consider here is a non-zero at the end. So if there is a survival, there's +1, and if there's death, is -1. We do not have any discount factor, so the episode return is always either 1 or -1. The policy here that we are aiming to learn is going to map all of our states to action which maximize the return, so the return of +1. Now there are different types of reinforcement learning. So we have, if you're familiar with reinforcement learning, we have online reinforcement learning and offline reinforcement learning. So in online reinforcement learning, we usually interact with the environment and we collect these experiences. And the environment can actually give us the reward. And once we collect this kind of data, we start optimizing for policy improvement. So like in our case, which is a neural network, we just like train the neural network based on what we collected. And then based on that policy, again, we act and we collect more data. But when it comes to medical application, this is very challenging because first of all, we cannot interact. We barely have good simulators for that. Second, it's very expensive. So we don't want to do a lot of mistakes. We cannot do a lot of failure per se. So that's why we kind of address this problem as an offline RL. This is where we have a fixed data set of data that is collected, let's say from ICU. And then we train a policy on this data set. So the model I'm going to talk about today is based on transformers, and it's an offline reinforcement learning model. So you're probably, some of you are familiar with transformers. They're good at sequential modeling. You all know that there are different ways of modeling sequences. There are recurrent neural networks. There are convnets that you can do, let's say 1D convolution, or transformers that have self-attention. So transformers are better choice in case of learning sequences. First of all, because they're like, they have self-attention, so they kind of involve pairwise interaction between all the input frames. They also enable parallel processing, so that's kind of avoid the stability issues. So you probably heard that in RNNs, because you kind of do things in a recurrent way, you have either vanishing gradient problems, so they're not stable in training. And finally, it allows combining information over longer range and aligning different modalities. So if you have different kind of input as a state, it's better to kind of use transformers. Now, how do we use RL now in sequence modeling? So for our choice, we use upside down RL. So what is the term of upside down RL? Usually, like when I explain, you have a function that's a policy that maps your state to your action. But there's also sometimes, like not all the time, you have this action or reward is sparse. So you can basically turn that into an upside problem and say, I want my policy to maps my target reward to go and path trajectory to actions. This is much better because you can actually tell your model that I would like to learn a model given this much reward. So when it comes to healthcare, you can say, I want to learn this policy given that I always want my patient to survive. So for this, we use a decision transformer model. There are several kind of works that's based on decision transformer in medical applications. And this is an instance of upside down RL, which conditions policy on desired reward, past state, and the action. So in terms of mathematics, so you have like a training trajectories of reward, state, and action, and then your reward to go is just the sum of your reward. And at this time, you kind of use, so this enables the user to choose what sort of reward to go you want. Now, this is like an overview of what is decision transformer, which is like we adapted it to the drug dosage problem. So you see like the S here is the state, and this is just like the information you have collected about your patient. Your reward to go is +1 or -1. On the test arm, you always set it to +1 because you want the patient to survive. But on the train, you have like real world data that's not always +1. Your action is discrete, so you always pick some level of drug dosage between the two. So that's 25 kind of combination. And you get this probability of your action. So you kind of take the action that optimizes the best. So it also uses the masked self-attention, which means that we do not look for, this kind of masks out whatever input that comes in future. So it only attends to the inputs that are from past. This is mainly because the future is not available during test time. Now, what we did, this is a work in progress with the 3 students from Mila, is that we adapted this medical decision transformer to kind of to predict the drug dosage. We used the mimic-3 dataset, and so the kind of novelty we have here is that apart from this +1 and -1 of the reward that you consider for, let's say for the ending of your trajectory, that is like whether the patient leaves ICU or not, we also define another kind of variable that we can condition on, and we call it acuity to go. So it's a vector of scores indicating status of patients, that's like cardiovascular, respiratory, etc. And so another systems that's time step t +1. So this is like what we can compute about the patient status at time step t +1. On the training, we have this kind of information because the state is always available, so we can compute it. But on the test time, I'm going to explain how we did that, because on the test time, we can go off these trajectories and then we do not have it inside the data. So, so this is like the basic structure on the training. So we train it on the mimic data set, and we kind of get this drug dosage recommendation as action. Now, if you want to try that on the test time, as I told you, we have this problem that like on the test time, you might predict a drug dosage that is very different from all your trajectories in the data set that would lead you to a state that does not exist in your data set. And for this reason, we have a second transformer here, which train to map states and actions to the successor state. So you give a sequence of a state and action, and you ask this other transformer to tell you what would be the state of the patient in the next time step. So this kind of acts as a simulator, but it's not really a simulator. It's just something that we train on the data. And using this, we can predict the next state, and then we can compute this acuity to go. We also use this kind of a transformer for computing another metric, because what we wanted to evaluate, not to only mimic the doctor, because doctor cannot be always perfect. So if we completely mimic the action of the doctor, it's not desirable. So we also used SOFA score and predicted action to see if our model predicts slightly off what the doctor predicts, do we actually improve over the policy of the doctor? So overall, this is our model on the inference, and this is our model on the training time. So with all of this in mind, then we did some comparison. So it's here, like the purple is the doctor policy and the green is our policy. It's pretty much similar. It mimics the same dosage, whereas our model tends to kind of give low drug dosage, especially in severe cases. And here again, the other graphs for each of the drugs that we have, showing the policy based on the numbers. And apart from metrics on only comparing with doctor action, we also use SOFA score to compare whether this medical decision transformer performs better than the pure behavior cloning. Pure behavior cloning is where you try to train a model that completely mimics the doctor. That's your like a default policy. So we see that overall we have a bit of improvement if we compute the SOFA score. Now we also, since we're using transformer, we can have like a bit of a look inside the weights that are trained for kind of interpretability, which is quite important in medical applications. So here you see the decision transformer and you see the MET-T. The MET-T has more variables, like has a bigger vector because we have this acuity to go. So you see you have cardiovascular and other parameters here. And when we actually like map the attention, like visualize the attention map, we see that like in the second layer, sorry, in the first layer, we see a better, like the weights indicates that the model kind of focuses on this kind of variable a lot more, which makes sense because one of the drugs actually have a like strong effect on the heartbeat. Now, like as I said, we're still working on our MET-T framework. So there are several things we would like to improve. One main issue is that, like when it comes to medical application, there's like a lot of unobserved factors that can influence mortality, like genetic problems that the patient might have, or the digest system is different. So that makes our MTP problem quite stochastic. So one way of doing that we were probably thinking to improve the stability is to not condition only on the return per patient, but to average over the cluster to stabilize. We also working currently on to have better explainability of learned policies, because just like having this visualization does not give us like the whole information. We would like to know better that like what action I took or what was in the vector of this information that recommends this kind of a drug dosage. That's something clinicians really want to know. So they want the model to tell them why it makes such a decision. So for that, there's another paper that can propagate this decision relevancy through the layers, so that at the end, if you receive a reward, you can kind of propagate all of this to your input, and that shows what caused this kind of a problem, or if you get a good reward. And then another thing we would like to take into account is to condition on multi-step acuity to go. So if you always condition on the current step and you optimize for the next step, it might not be an immediate reward all the time. So that's something we would like to see whether we can condition on multi-step. This is again very important because like one main challenge in designing reinforcement learning for medical application is that you usually like have a very, very sparse reward. So you need to take a lot of action, and at the end there is only one or -1, which does not give you enough information like throughout the time whether you're doing something right. So this kind of acuity to go kind of one way of define this intermediate dense rewards to tell us how to improve the model. And then we would like to, and we have 2 other projects that we would like to apply these kind of methods to other applications like stress hyperammonia treatments or when it comes to antibiotic dosing. That's it. I prepared for 20 minutes. I think that was what you told me. And here's my group and the students who are working. Some of them are working on medical applications. And thank you. If you have any question, feel free to ask.
Thank you very much, Dr. Kahou. 20 minutes is perfect. Actually, now we have good time for questions, so the timing is perfect. So thank you so much for your presentation, for presenting your latest research. That's actually super interesting. The participants might not be super familiar with transformers yet, but they have a workshop tomorrow about transformers, so they will have the opportunity to learn more about it. So now we can start the question period. So feel free to unmute, raise a hand, or put the question you have in the chat. So I already see one question. So maybe I'm going to start with that. So it's a question from Sohab. As we're dealing with living organism, is it better to simulate a similar population and let the model first train on those provided data variables and then implement on real case scenarios? Or from the very beginning, let the model receives data of patients, then prescribe the dosage option with physician supervision, and finally watch and optimize based on consequences?
So that again caused a lot of open problems in reinforcement learning. So if you want, there are currently simulators for sepsis treatment, but the simulator itself, to build like an accurate simulator, is very difficult. So the simulator is not perfect. And then if you train on the simulator, you can train it online on the simulator and kind of optimize with mimic offline data. But when you again put it in ICU, it's going to be the same challenge in my eyes, because it's from sim to real. Again, there are a lot of things to consider and optimize. But I know there are researchers, like there are people at Saint Justine working on improving simulators. They're mostly physics-based to kind of understand how sepsis works and what treatments are good. So
thank you very much. I might have a follow-up question. Like earlier with the talk of Dr. Anazodo, we talked about some sort of out of distribution patients, like patient with TD and this kind of example. How would your medical transformer handle such data that it hasn't seen during the training if it uses a fixed data set for training?
So the reason like we use reinforcement learning is because it enables you to kind of go slightly off your trajectory. So if you go off your trajectory, which means, let's say I train my reinforcement learning model on a fixed data set, and on test time, I have a new patient with totally different state. So it allows you to go slightly off policy, but it's not going to adapt perfectly in long term. So the problem still exists when you, in my perfect, going to give you some sort of a good approximation for 30 time steps, which are like 4 hours in between. But if you would like to it's not ideal. Usually if you want a perfect generalization, you need a better data. For that, you can work a lot on the model itself, but I think both are hand in hand. You need good data and you need to account for generalization. So one reason we designed this state predictor separately from policy was because we did not want to have the state predictor. If you have all in one model, because transformers are very, very strong, it would overfit a lot more to your trained data. And then it would be worse in generalization if you have a patient, let's say, with a different demographic. I hope that answers the question.
What is the difference? I'm following up with question because I don't see a question on the chat. So what is the main difference if you use reinforcement learning compared to supervised learning for these cases where you have out of distribution data? Is reinforcement learning better at handling these cases?
So when I presented the result, this behavior cloning is supervised learning. So it's just takes the state, there's a neural net, and predicts the action. The action we consider them ground truths because they come from the doctor.
Okay, thank you very much.
So that's supervised learning. So we see a bit of improvement, but not if your metric is the difference between the action of the doctor, then supervised learning is good because you perfectly mimic your doctor. But that does not mean that the doctor, then in that case, you kind of trust your expert so much that never makes mistakes. So your model cannot be better than the doctor per se.
Okay, thank you so much. So I see another question on the chat. What's the best approach for leveraging decision transformers in this drug dosage recommendation use case? Online reinforcement learning or offline reinforcement learning?
I guess both are fine. I think we use offline because mimic data set is an offline data. If you do online, then you need simulator. So then you need to use the simulator. So when you're doing online learning, you actively interact with the simulator that gives you the reward. So it's not that I have a data set and I train all. It's something like an actively you update. There are ways that you can learn, like you can combine decision transformers. There's an online version of decision transformers, so you can train offline and then put it online and fine tune it if you would like to make it like a lot better. But that's not what we did. So we just did the offline version based on the mimic. I guess I cannot say which one is better. It might be
combination.
Again, metrics are not perfect. So like the metric of mimicking the doctor is not perfect. The metric of computing SOFA as well is not a perfect metric. So you can report on that and say, okay, based on this, I see this model does better. But it doesn't mean that if you use it in another hospital, that gives you exactly the same result. Those are all the challenges I think in medical research.
Indeed. Thank you very much. So I don't see any more question on the chat. Maybe I can ask a quick follow-up on what you just said. So would masking transformer, like all of the mask transformer abilities, would that help with handling missing data in your data set? Let's say you built a model based on some characteristic of the patient that are not available for another patient. Would transformer abilities help with that?
You can mask them if they don't exist. So like transformers are, I think someone asked what are the good self-supervised way for time series.
Mm-hmm.
So transformers are designed for language models, which are like kind of time series, but they are pre-training methods of transformers when it masks out your input and tries to predict that. So that's just a pre-training way of your network. Now, if they're actually missing by the nature of data, you can pre-train to predict that missing information. So you can pre-train on predicting the missing information and then add your reward function and optimize for the reward. That's something I can't say you can use, but apart from that, if it doesn't exist, you can mask it out. But it's challenging if you, if you have a lot of missing information, you won't be able to learn much.
Well, thank you so much for sharing all of your knowledge. That was super interesting. So I don't see any more questions on the chat. So maybe we can wrap it up for today. This is perfect timing. It's noon. So once again, I would like to thank you very much, Dr. Kahou, and also Dr. Anazodo. I don't know if they left, but thank you very much for your time. We know it's a Saturday morning and you put a lot of effort in this presentation and work. So thank you very much. And the participants, you will have the opportunity to learn more about transformers and their implementation tomorrow. So bear with us for tomorrow. And I wish you all a very nice Saturday. Thank you all for joining, and I will see you tomorrow, all the participants.
Thank you, Eugene and Sebastian. Bye-bye.
Thank you very much. Thank you, Dr.
Bye.
Kahou. Thank you.
Bye.
Have a good
Thank you.
bye.